From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Tuesday, the 16th of September, 2025. Today is a bittersweet LabMind episode for me because after 7 years, this will be my last time hosting the podcast. Loyal listeners, you need not fear. We have recruited a brilliant and gifted academic pathologist to take over the hosting duties. Many of you already know Dr. John Gensen from his national work in laboratory medicine, or you may remember him from previous LabMind episodes, where John was either the co-host or the guest. John is a very thoughtful individual, and he's going to be a fantastic host. Also, in case you are curious about my new professional opportunity that has led to this transition, then you'll just have to tune into the next episode where John will be interviewing me, and we'll also be reflecting on all of our amazing guests and stories that we've had on LabMind over the past 7 years. Which brings me to today's episode. I am extremely pleased that for this, my ultimate interview, I was able to recruit Dr. Shaiba Ansari-Ali onto the show. Dr. Ansari-Ali is a rheumatologist at Northwestern Medicine. She received her medical degree at the University of Michigan, followed by internal medicine residency at the University of Illinois, Chicago, and a rheumatology fellowship at Loyola University of Chicago. She is also the author of the book, When the Doctor Has a Stroke, How I Recovered and You Can Too. This is available on Amazon in both paperback and ebook. And she also has a YouTube channel you might want to check out entitled Mansplaining Medicine, where she explains all kinds of different medical concepts to the general public. Dr. Shaiba Ansari-Ali, welcome to LabMind.
Thank you so much, Brian. I'm honored to be here.
So how old were you when you first discovered that you were going to be a physician?
I want to say before kindergarten, because my uncle was a cardiologist and we always used to play in his library, and he used to sign his papers as Dr. Ansari, MD, FACP. So I remember in kindergarten, when my teacher asked me to write my name, I signed it Shaiba, MD, FACP. And she was like, that's not how you write your name. And I was like, well, that is how you write my name in my family. So I think that's when it started. But my parents say I was always giving fake injections to my brothers and things like that. Always chose a stethoscope over a doll to play with, probably around 4-ish. And then all through my schooling, all through my education, I know a lot of people ask me later in life, what was your plan B if you didn't become a doctor? And I was like, I didn't have a plan B. My plan A was always to be a doctor.
That could have been a self-imposed burden. Was that a source of anxiety and stress that here's a goal and now I need to achieve it? Or was it a clarifying thing for you as you were growing up and going to school?
I think for me, it was a clarifying thing up until medical school, because all the way up until medical school, I wanted to do OB-GYN. So I shadowed an OB-GYN. I actually scrubbed into my mom's own hysterectomy. I scrubbed into the doctor because I was working with her at the time. And so all through medical school, I was like OB-GYN, OB-GYN, OB-GYN. And then I did OB-GYN for a year, but 6 days into it, I was like, no, I don't want to do this. This cannot be the rest of my life. And so then I switched to medicine, but because I'd signed a contract, I finished out the intern year in OB-GYN.
Yeah.
And then I switched to medicine, which is why it took me 4 years to complete the residency instead of the normal 3. So at that point, I knew I still wanted to be a doctor, but I'd chosen the wrong type. And when you go until the age of 22, 21, if you're only focused on being an OB-GYN and nothing else, that was kind of life changing for me. But then after taking that leap, then it was easy to switch.
So rheumatology is very different from OB-GYN. I think of rheumatology as a classic cognitive specialty, and OB is very much surgery, right?
Yes, definitely.
Not that surgeons aren't cognitive. That's not what I'm saying. I'm saying there's definitely a difference between procedural specialties and cognitive specialties.
And I think that also goes back to, I probably missed the clues a little bit, but when I was younger, I liked reading Sherlock Holmes a lot, like
Mhm.
exorbitant amount. I would wait till I forgot the end and then I would read it again, try to figure out what the ending was. But later on in life, when I was a rheumatologist, I figured out that Sir Arthur Conan Doyle, who wrote Sherlock Holmes, was a physician. And he actually was an eye doctor, but he wasn't that successful. So to make extra money on the side, he wrote. And he used to get paid by the page, which is why some of his early stories are very long, because he would print them for a magazine. And his mentor was a Dr. Bell, who was a Scottish surgeon who could do what Holmes did in his books. He would have students stand up in class and he would say, "Oh, you're from this part of England, your parents do this, and your whole family does this, and you had this for breakfast." He could basically tell them everything in class. And he was the first, I think, in Sir Arthur Conan Doyle's life anyway, to say that you have to be an observationalist when you're a good
Hmm.
physician. So he
Yeah.
would see patients. One time I remember I was reading something where a woman came with her son to clinic and the kid was wearing a coat that was too big. And so he said, "Where's your other child?" And the woman's like, "How did you know I have another child?" And he's like, "Well, you're using a larger coat for this child. So it either was passed down or you left the other child at home." And so he picked up on very small clues like that. So I did OB-GYN 6 days into. I'm like, "No, I can't do this." So I did a year of that, switched to medicine, actually finished medicine, got a job as a hospitalist in downtown Chicago. I was like ready to go. Senior year, everybody had matched for their fellowships and everything like that. And I think I did a 2-week rotation with an amazing rheumatologist at U of I. Dr. Swedler. And Dr. Swedler was the one in the hospital when people didn't know what was going on, they would say, "Let's curbside Swedler," because that was the phrase, Swedler curbside. And we'd go curbside him, he'd talk to the patient, he'd look at their chart, and he would examine them. He's like, "Oh, this is the diagnosis." And 99% of the time he was right. So he made everything look really cool. And he gave you the backstory of every little thing on rounds. So I did 2 weeks with him and I was like, I want to be a rheumatologist. I saw the light. I went to my mentor, my advisor, and she was like, "Well, Dr. Swedler makes everybody want to be a rheumatologist. So now you have to go rotate with somebody who doesn't want you to be a rheumatologist." He made me rotate with a really boring rheumatologist who shall remain nameless. And I did 3 weeks for her. And instead of like feeling like I was almost going to die, I actually liked it. And so then I pursued it. But of course, it was way after the match, right, for fellowship, because this I'm talking like May, but match happens in
Yeah.
March. So it's like a month or so after the match. And so I asked my advisor, "What should I do? I really want to go into rheumatology." And so she was like, "Well, why don't you just call up different program directors in the area and get your name out there and plan on doing 1 year in research?" I'm like, "Okay," and just tell me you're interested. It's like, "Okay." So I called up the first one. They said, "That's great." I called up the Loyola one and they said, "You know what? Our rheumatology fellow for next year just called yesterday and canceled and said he can't come because of a family emergency. So if you want to come and interview with us, it'd be great." Because they had already reached out to the other people on their list and they had already taken positions.
Yeah.
I went, I interviewed, and evidently I found out later that there are two attendings that have very opposite personalities and they both liked me. So then they're like, I was the only candidate that they both liked. So I got the gig.
Perfect. Let's go back to your story and the book that you wrote. In the year 2016, I understand that you were in a busy medical practice and had a young family, and everything was great, but maybe really busy. And it sounds like you were pretty healthy, but then things happened. So tell us what happened.
From 2012 to 2016, I was extremely busy at work. I was part of a two-man practice. And even though I only worked 3 days a week, we were seeing full-time load of patients because we would see like 20, 25 patients a day, quite a bit for our private practice. And I was in that mode where you're at the top of your game, your schedule is full, you're making a lot of money, you can do a lot of things that you couldn't do before. I mean, you come out of the slums of residency and then fellowship, you're still kind of living near the poverty line, but not quite, you know? And then after that, your clinic is half empty many years, and then suddenly you're just full. In that 4-year period, I had developed this cough variant asthma. And so what I would do is I would pick up a virus in September and I would cough my way all the way through spring, like intermittently, and at least 4 months straight at a time. So it would resolve. I would get another virus and I would cough my way until March. And as a result, for about 4 years, I was coughing for about 4 months straight for 4 years in a row, if not more. And what had happened was in 2016, I passed my boards, and I actually wasn't even supposed to take the boards in the spring of 2016. I was supposed to take in the winter of 2016. But I had a friend who was studying for it, and she was like, "Well, I'm studying for it." And I'm like, "Well, if I'm studying for it, I might as well just take it now and get it out of the way." So I did that. And then I went to Disney World because now finally I had that I could put towards a vacation because before then everything was on hold. Evidently, I was coughing so hard that, to give an example, Brian, of how much I would cough, go in and see the patient, introduce myself, step out and cough, go in and ask a few questions, step out and cough, go in and finish the rest of the history, step out and cough, examine the patient in the beginning, step out and cough, go back in and finish the exam, step out and cough, and then go back in and do the assessment plan, and then step out and cough again. So I was coughing like every minute and a half, and it was so bad that my ribs would hurt after some time. And I didn't know this, but my staff in October, September, they were secretly blocking my schedule and not telling me about it because they kind of knew I would cough so hard. There'd be a few days I just couldn't be able to come to work, and then I would resume again.
So this sounds really extreme.
It would be a cough that would bother me during the daytime, but at nighttime I was okay. And if I didn't exert myself too much, I was okay. So whenever I was okay, whenever the virus passed, I'd be great for like 4 months. By the time I think like, maybe I should go see somebody, it was gone. So I wouldn't do that.
So what happened next?
So in 2016, that Thursday was the last day of June. I had seen a bunch of patients in clinic, but I didn't have time to finish the notes. So Friday morning, got up, did my usual exercise and all that. So I sat down to write my notes, and I'm sitting on a bed in the guest bedroom, and I'm writing my notes, and suddenly the room starts to spin. But the weird thing is, it starts to spin vertically and horizontally. Like it wasn't just a one-way type of thing. And for a second, I thought maybe it's a migraine that's coming on because I used to get a lot of migraines. And about a week or 2 weeks before, I was the first time I'd seen an aura with a migraine. I'd never seen one before with this flashing lights, evidently. I'd never had that in my life, but 2 weeks before I had. And also, about 2 weeks before, after a very big coughing spell at work, I got this intense pain down my neck, almost like an electric shock. And it was just like a twinge, that somebody had taken a knife to the back of my neck, but then it went away. And for that whole week, almost 10 days, every night I couldn't sleep. That pain was so intense. But during the day, I was fine. During the day, I would hardly notice it. I would take my Tylenol, I would keep going. But then that Thursday night, the pain subsided and I was able to get good sleep. I woke up on Friday and I was like, okay, great, we're back to normal again. And then the room started to spin. And so then I got up and I was like, something's wrong. And then I realized I was lurching. I wasn't walking straight. So then I lurched to the master bedroom. And thank God my husband was working from home that day. And I woke him up and I said, I don't feel well. The room is spinning. He's like, oh, you're probably just having a migraine. I said, no, this isn't a migraine. So I went into the bathroom and I threw up like 5 times. And then I just felt so cold and clammy. I felt like I was going to pass out. So I laid on the tile on the bathroom floor thinking the cold will hit my cheek and I'll feel better. And that's when I realized I couldn't move. Like I was choking on my saliva. And for some reason at that time, I wasn't afraid. I was like, wow, this is very interesting. Why am I not moving? Like, why can't I move?
Anyone else, including me, would have been absolutely terrified at that moment. So I'm fascinated that you found this interesting.
I found it very interesting, like, because the first one I was having the whole dizzy thing, I was like, maybe it's Meniere's disease, but I was 42, and I know that happens around the age of 50 and beyond. And I didn't have any of the risk factors for Meniere's disease. And then when this happened, the whole time I was trying to figure out what's going on. But when I couldn't move, I'm like, oh, it's locked-in syndrome. That's what it is.
For anyone who knows what that is, I can't think of anything that would be more existentially terrifying.
When we were medical students, we had to read this book about this guy who had locked-in syndrome. It was required reading in medical school at Michigan because our neurologist wanted us to be empathetic to the neurology patients. And so when we saw a patient who in a coma or who was sedated, we never assumed they couldn't hear us or anything. We treated them with utmost respect like we would a normal patient. So he had described the locked-in syndrome. And as a medical student, when they say find the lesion, right? If you're having this issue, find the lesion in the brain. So I was like, oh, either the middle or third of my internal capsule is not getting any blood. That's the only way this could have happened, right? I've completely knocked out the motor part of my brain. So it must be lectin syndrome. So that's when I kind of started talking to myself. I was like talking my way through this. I was like, that's so interesting.
Just in case there are any listeners who aren't familiar with the term locked-in syndrome, maybe a quick explanation of what that means.
So lectin syndrome is basically where you don't get enough blood to a part of the brain. And it's the part of the brain that controls motor, lets you move. So usually lectin syndrome is when people are alive on the inside, but they look dead on the outside because they can't move. And some people will have what's called complete locked-in syndrome, where they can't move anything. And some people have incomplete, where they can still move their eyes or maybe one or two things on their face. But either way, usually people will end up being paralyzed from the neck down, usually for the rest of their life. That's the most common outcome for locked-in syndrome. Because you're alive on the inside, but you look dead on the outside.
So tell us what happened next. You're lying there on the floor.
Yeah,
You cannot move. You're at
right.
risk of choking.
Choking on my saliva. That was kind of the neat part because that's when I figured it out, right? But anyway, so my husband comes in because he heard me. He looks at me on the floor, and I remember him looking down at me, and he's like shaking me. I'm like, oh God, please don't do that. Because I can't move. And then he's like, should I call the ambulance? Yeah, yesterday. You should have called them a long time ago, even before you ran in here. But he called the ambulance. And then I'm kind of in and out, Brian. I'm in and I'm out. But the next thing I know, I wake up and I'm strapped into a stretcher, and the paramedics are throwing me down the stairs. I'm afraid of heights. So I was like really high up for me. I'm like, oh, this is not good. And then they take me out to the ambulance. They keep telling me to wake up, and I can't move. I can't tell them I can't wake up. And so they put an IV into me and I don't feel it. I was like, okay, I must have lost some sensory too. Then that's weird. Why would I lose both? And then they keep doing these sternal rubs to try to wake me up. And sternal rubs, for those listeners who don't know, is if you make a full fist and your knuckles and you're basically burrowing your knuckles into the breastbone of a patient. And usually that's the last feeling to go. So if a patient is near death, but they can still have a chance to come back, they will come back with the sternal rub because it hurts so much, excruciatingly painful. And so they kept doing sternal rubs on me to wake me up because my husband had said she had a migraine. So I think they had thought that I had taken some medicines and I'd overdosed. And at that time, this was 2016, the heroin epidemic was still out there. I believe they wasted a few minutes at least on the driveway. And then my husband knocked on the window and told them, why are you guys still here? And they said, well, she overdosed. And he's like, no, I told you she didn't take any medicines. And so then that's when they took me to the emergency room. And the next thing I know, I wake up in the emergency room. The nurses are running around doing their nurse things, saving people's lives. And then the doctors, is July 1st. I know it's July 1st, right? And again, for those of you guys not in the biz, July 1st is when the new residents come in. They're highly supervised. Back in 2016, there used to be this myth that when residents come on, more mistakes are made, but actually that hasn't been proven because they're more supervised. But I was in that mindset that, oh my God, the ER is full of residents and they have no idea what's going on, and I don't need a resident. So there was a guy sitting at the end of the bed. I felt frightened and he looked frightened. He was sitting at the end of the bed and he was just staring at me, and I'm thinking, oh my God, you were a medical student like 2 weeks ago, weren't you? I'm just thinking that. But then the neurologist comes in and he does a clinical exam. He tried to have me move a leg or a hand or blink and something like that, shined light in my eye. And he said three things. He said she's having a stroke, she needs TPA, pass her through the scanner, and then open up the cath lab, and then he left. And I was like, oh my God, this guy. And he was a really snappy dresser, drew carry glasses. That's what I remember seeing anyway. He left, and I was like, everybody listen to that guy because he clearly knows what he's doing. And so that's what they did.
Thank goodness that guy came in quickly.
Later on, I found out my brother works in healthcare, and he asked one of his friends, who is the best neurologist you would refer to in the Chicago area? And he mentioned that guy. He said, oh, that guy. Again, I'm in and out. But then I wake up in a dark room and I have a jolt, something like electricity go through me. So I knew they'd given me the TPA, which is a clot buster, basically. And so I had a major clot somewhere that was blocking a big portion of blood to the brain. So they'd given me that clot buster. It opened up the clot. I felt some movement. And the next thing I wake up, I'm intubated and in the cath lab. So I'm on a breathing tube, and there's a surgeon there, a neurointerventional radiologist. They have like the longest name ever, Brian. So they are there, they're looking on a screen up on the wall, and they're going to make a small cut in my right leg, and they're going to put a wire in the femoral artery, and they're going to pass it all the way up to the brain. And it's almost like a fishing line, right? They're going to go up and try to find if there's any clot left and just take it out if they can. So he comes over to me with this really sharp scalpel, and I couldn't feel the IV when the other guy put it in. But I'm like, oh my God, if they gave me the TPI, I had my feeling back. Right? So he's going to make a cut in my leg and I'm going to feel it, but I'm not going to be able to move. But he made the cut. I didn't feel it. And then I was happy I didn't feel it. But then at the same time, I got not worried, but I was like, well, okay, now what does that mean? I didn't get my full sensory back. They threaded the wire. He didn't find anything. Thank God. It was all gone by then. And I had recovered, and I spent, I want to say 48 hours in the ICU, but I had a lot of brain swelling is what they told me. So the whole time in ICU, I just felt like I was on a roller coaster. I just felt like that whole spinning thing. I wasn't spinning horizontally anymore, but it was vertically. So I felt like I was on the top of a roller coaster going down, top of a roller coaster every time I opened my eyes.
It sounds exhausting.
They had me sedated for a big part of it, but they didn't want me sedated fully because they wanted to know how much neural function I had.
Yeah.
In the ICU is when the rehab doctor came and evaluated me, and he said, I think you'd be a good candidate for a rehab hospital called Marion Joy in Chicago. And then I think on day 3 or 4, I was transferred to rehab.
There was another story in your book that I wanted you to tell, and it had to do with your leg after the procedure.
Yeah.
I'm impressed that you can laugh about these things. These are serious issues.
I think when you're young and kind of stupid, you think you're never going to die, right? So I was 42, which is young now.
I'm I'm glad that we can say that 42 is young.
So you don't really think about the option of dying, right? You always think you're going to get through this, but it's going to be kind of weird. Maybe you'll have a few jolts along the way. So when I went to rehab, I'm the one out of 1,000 people that has this accessory artery in the back of the femoral artery. I think it's a very small one. And so when they had closed up the femoral artery, they had nicked that artery. So I was slowly dripping blood into my thigh area, like a drop at a time. So when I went to rehab, I was in too much pain. Like 3 days later, it was built up. I couldn't do rehab effectively. And it was very red and tender in the area. And so I wasn't able to do their exercises. And they did have infectious disease consult me because I was running low grade fevers, I was becoming tachycardic. And he didn't really do a full exam, one of those prison exams from across the room, like, hey, you're okay, right? One of those type of exams. And so they treated it as a yeast infection, but within the first week of being at rehab,
So they thought it was just a rash.
I thought it was just a rash. I was putting a heating pad on it, and I'm talking to my husband. My husband's like, "Are you okay?" I'm like, "Yeah, why?" He's like, "There's blood all over the bed." I had been given a very strong blood thinner, and I was on a blood thinner at the rehab. Then they called the code. I became hypotensive, fevers. They were trying to find IV excesses and stuff like that. And then they carted me back to the hospital. The ER attending was one of my friends who was my boss when I was in residency.
Oh man.
Yeah, and like, tell me, he's like, Shaiba? He saw it right away and he's like, oh, this is a vascular thing. So he put in a vascular consult and a CT. So I got the CT. They found a groin hematoma and they said it's multi-layered and cystic, so you need surgery. But at that time, there were newer residents, newer senior resident, and newer intern. I think they saw that there was a new ID fellow. And so they talked to her and she's like, oh, we can cure this with antibiotics. You can't do that with anesthesia. They put me on IV antibiotics, but I was still having more and more pain. I was still having fevers. So I was taking Tylenol around the clock. They were giving me IV antibiotics around the clock. They put in a PICC line in me. And literally 12 hours before I was supposed to get my ride back to the rehab, a night nurse said, you shouldn't be having this much pain. I'm like, I know. And so she took the whole bandage off and she looked and she's like, this is infected. Now, being a nurse, you can call another nurse, but if you call another doctor, then you're overstepping people, right? So she called the wound care nurse, which is a friend of hers. And the wound care nurse came and saw me and was like, oh my God, she needs to go to surgery. And the night nurse is like, I know. And I'm like, I know. And that's the vascular surgeon came that night and he saw me. They put me on a schedule for the next morning. And then they did the surgery. But he said that he had to basically scoop out infected blood by the handfuls because it had all clotted and congealed.
Oh, yuck.
And he had to leave a couple of drains in because they couldn't get everything out. So drains were like little straws that are connected to little balloons. And so then they just slowly drain and then you can pull the drains later. But then I had a PICC line in or the antibiotic. I felt so much better. I was on Percocet, so I was crazy happy. Right? Everything looked great.
Okay, so let's pause for just a minute. And I'd like to go back through your story again. And let's talk about the misdiagnoses that happened along the way and why you think they happened and the consequences. Because after all, this is a diagnostic podcast. You are a diagnostician. Most of our audience are laboratory people who think in terms of diagnoses. So the first one, if you'll forgive me a little bit, I want to put this one on you because I think you misdiagnosed your own cough. Do you agree with that?
I totally agree with that because I was so busy. I thought it was allergies and I thought it was a virus. And every time I would go to get it checked out, I'd get better. So I totally mistook myself for sure.
From your description, the severity was actually quite high.
It was bad.
I suspect that this might be common among doctors. Do you think that doctors tend to underplay their own symptoms?
I think so. I should have put it together. You're coughing more and you're getting this, or you're getting a difference in your migraines. Thing is, we are so busy, number one. And then number two, people come to us for answers. And for us to actually go to somebody else, it doesn't feel right. Well, I'm not the patient, I'm the doctor.
That's understandable. Unfortunately, it contributed to a bad outcome. And then the cough got worse, and you described the stabbing pain in the back of your neck that was so much pain that you couldn't sleep. Have any neurologists chastised you for brushing that one off?
I did, and being a rheumatologist and having room friends, I was on muscle relaxers, I was on steroids, I was on anything to get me through the night, save other than controlled substances. But during the day, again, because I was fine, I could keep working. And I think that's what this experience has taught me the most is that you are truly only irreplaceable to your family, right? Your kids can't go get another mother, your parents can't get another daughter, but your patients can always get another doctor. But when we're in this mode, we think this is it. We're it. We have to be there for our patients no matter what. You keep putting things to the side for that.
The next major misdiagnosis that appears not to have had a catastrophic consequence, but it really could have, was that the EMTs were sitting in your driveway thinking that you'd overdosed. What do you think of that?
I think they must have seen a lot of people overdosing recently for the early 2000s, people using a lot more drugs and such. So I think they're seeing what they had always seen. And they'd heard my husband say she had a migraine. Then he also said she didn't take her medications, but also their pressure too to do what's right for the patient immediately.
Right.
Their biggest thought was like, let's do this. And I think the third thing was I had such a rare type of stroke. It was such a rare presentation. If you look online, Lachlan syndrome sometimes takes years to get diagnosed. So it's one of those that's a very rare thing. You don't see it that commonly. It wasn't like I had a facial droop, couldn't move half my body. It wasn't like that. I would look completely dead.
Yeah. We'll give them a pass on that.
Yes, I think you should give a pass to pretty much anything in medicine.
It was a high stakes situation because if they had delayed any longer in getting you to the hospital, then you may not have made it. You may have had more permanent deficit. I mean, what's the phrase that the neurologists use when they talk about strokes? Time is brain.
For sure, that's true. And the thing is, the hospital they took me to wasn't even my regular hospital. So I'm a big believer in things happen for a reason. For whatever reason, I was delayed on the driveway. I was taken to a different hospital. And then I had this amazing neurologist who wasn't really working. There was just doing shifts there. And then even the ER doctor, my friend, he was just picking up an extra shift at night. So I was kind of in the right place at the right time everywhere. So yeah, everything can have a bad outcome. But if it doesn't, it doesn't.
So the score now is two significant misdiagnoses, but one absolutely brilliant neurologic
Yes.
diagnosis, which saved the day.
And it was a clinical one. It's not like he had scans.
Right.
If you look at it, his diagnosis was completely clinical.
An old fashioned physical exam diagnosis.
And if you look at it, Brian, right, all the great physicians we talk about in history, Hippocrates, 400 BC, Avicenna in 1000 AD, right? Then you talk about Osler in the early 1900s. They were all clinicians. They were diagnosticians based on what they could see, not from a lab test. I hate to say it. I think we put too much of a burden your people. We put too much of a burden on pathologists and lab tests. Give us the diagnosis. No, confirm the diagnosis. Our approach should be that.
Absolutely. They're data points, but they need to be put in context because if they're not, they can lead you to the wrong answers.
Yeah. And you find things on labs and tests and scans that don't contribute at all to disease. They're just there. They're just normal mother nature, wear and tear, whatever. I have so many patients with lab tests that don't have a disease, but they get worried because on the internet they read about that.
Well, some of those can be misleading and can take you down a pathway that doesn't benefit anyone because the test result's just a little bit out the normal range.
Yeah. And then normal too is different, right?
All right. We think that normal means for this patient, but it really means over some population that may or may not represent the patient at all. Okay. And then the last misdiagnosis you already covered in quite a bit of detail, but the situation with the bleeding into your leg that wasn't picked up right away
Yeah.
really led to some horrific consequences. Sounds like you have eventually recovered from that, but that sounds pretty horrible.
That was very painful, especially when I was septic. I knew I was having fevers. I was hypotensive, and tachycardic. and I bled, and the nurses came and they just were holding pressure. And I distinctly remember this rehab residents, like two of them came and they had not been residents for very long. And they had said, well, in front of me, I'm the patient and nobody knows I'm a doctor, right? Well, it's no good holding pressure. She's on a blood thinner. I'm like, don't say that. You know, I'm right here. The nurses looked at them like, are you crazy? We're going to try to do what we can do. You can't
Right.
let her bleed to death. They said, we'll give her some fluids. She'll be fine. And we'll come back in an hour and check on her. But then there was a redheaded nurse. She whispered in my ear. She's like, you're septic. I'm like, I know. And she knows a doctor. And so she was like, I'm going to go to the charge nurse and tell them we need to go back to the hospital. And so they started the ball rolling. So by the time the residents came back and said, well, we think she needs to go to the hospital, the ambulance is left on their way.
So thank goodness for experienced nurses in this case, who again were doing diagnosis.
I think it is. I can never say enough good things about nurses. They basically save us from making the mistakes that could kill our patients.
And that absolutely happened in your case, it sounds like.
Yes, yes.
So when you started your story, you were having the stroke and you're experiencing it, and you described what sounds like doctor mode, self-diagnosing and analyzing your situation. Was there any point along the way when you transitioned into what we would traditionally think of as patient mode?
I think halfway through rehab, the first week I was there was very irritable because I was in pain. So I don't remember too much of that. I was a very demanding patient, but I was also a doctor kind of thing. So it was very demanding. But then when I went back to rehab, suddenly it really hit me. I can't write again. I can't hear fully out of one ear again. And I was fully wheelchair bound. I had to learn how to walk again and I had to learn how to talk again. So I think there were a few days where I was very depressed. This was actually started by a group of doctors around me. And one of them asked me, what did you used to do? And I think that just hit me. I was like, what do you mean, what did I used to do?
That's a really harsh question.
I was like, what do you mean I used to do this? And to me, that automatically meant, does that mean I can't go back to what I did?
Right.
Because remember, I spent my whole life trying to be a doctor. Does that mean that you think I'm not going to be able to go back? Luckily, I have really good colleagues that visit me every day in rehab. And my friend was like, that's not what they meant. They were just trying to make small talk. That's also where I switched how I looked at things because up until then, I was so busy trying to get back to exactly where I was. And then I realized I couldn't do that. So I think I had to slow down. I had to become the patient. I had to take advice. And I remember one day I was very upset because I couldn't write clearly anymore. And one of the rehab guys was like, you see that lady over there in the wheelchair? She can write beautifully. I'm like, thanks a lot, right? Because I can't write. That's what you're going to point out now, right? And he's like, yeah, but she can never walk again. There's always a trade off.
Yeah.
Be thankful for what you have. After that, I became the patient. But in addition to being the patient, I was like, okay, if I'm going to be the patient, I'm going to be the best patient ever. And I'm going to use my doctor knowledge to get there. And one of the things I know from it being a doctor, you have about 90 days to get as much of your brain back as you can. And this all goes back to Dr. Frankel, the father of rehab medicine, who lived around in the 1860s. And he's a neurologist. And in 1884, he's practicing. And at that time, when people had a stroke, the advice was go home, get bed rest, and get some blood to your brain, and hope you live another year type of thing. And he had a patient, a farmer in his clinic, that failed one of the neurological tests. And the farmer said, what's wrong? Frankel says, well, you had a stroke. You have to go home and rest. The farmer comes back in 3 months and does everything perfectly. And Frankel's like, how did you do this neurological test perfectly? And the farmer's like, well, I knew it was going to be tested. So I practiced every day. And so that's where that idea of brain plasticity comes from, the idea that we can build new pathways. And I knew that this started with Frankel in the 1890s or so, but then in World War I, you had more rehab places after the soldiers came back. So this is more and more of an idea that started then. So I knew as a doctor, I had 90 days. So even if it hurt, I was going to try to do it. And so whatever they did in rehab, I did it like 1,000 times more to try to make that pathway. So if they had me use Frankel's ladder, which is like that agility ladder, they would have me practice stepping backwards, forward, side to side, and stuff like that. I would try doing that just with the tile shapes on the floor. If they had me practice making a turn that day in rehab, I would make tight turns in my room like 50 times more that same day so I could get that pathway back. When they had me do tongue twisters, they had me do 10 or 8 tongue twisters one day just to clear up my speech. When I came home after rehab, I downloaded 500 tongue twisters from the internet. I printed them out and I went through them 3 times a day. That's 1,500 times. But I went through them 3 times a day and I rebuilt those pathways. And the ones I could do, I would put them off to the side and I would keep hitting the hard ones. So like a month later, my speech had cleared up. I had gone from being somebody who was completely dysphagic to somebody who could talk again. And then I also created a list of words that I knew I could use in the morning when I'm fresh. I can use a lot of words, but then as the afternoon comes around, I get tired. So there are certain words, especially in front of patients, that I don't use anymore. And I'm very good now at word finding. Before I would say a sentence and maybe the third or fourth word, I have trouble like, what word should I choose? And now in my mind, I already have 3 or 4 options for that word. So if I can't
Mm.
say this word, I can say the other two. So I can pick one. And I do it more seamlessly now. People can't really tell when I'm doing that. And I can't tell because it's automatic.
I can't tell. As we've been talking, you've been describing some of the things you're experiencing, but none of it would be apparent to me.
Yeah. And one of the things I learned is that I have to practice in front of a mirror and I videotape myself is I have to move my tongue differently on the inside to get the right sound on the outside. But it was all about doing as much as I can over and over and over again and building those pathways in my brain so I could get back to where I was. And thank God I passed the boards, right? Because if I had to take my rheumatology boards that winter of 2016, it would have been game over for me. But I was able to go back to work just 3 months after having my stroke. But the difference was I was very slow and I would get exhausted easily. So before I was just telling you, I could see 20 patients, 20, 25 patients. After my stroke, it would take me like 6 hours to see 4 patients because I was just so slow, so slow.
Still, though, after everything you went through and all of the rehab you need to do to be able to be seeing patients in 3 months, I think that's amazing.
Yeah, and I'm up to 8 or 9 patients a day. My max is about
Mhm.
10. The whole thing is that I can't write. So because I can't write, when a patient comes in the room, I basically have to memorize it's almost like reading a short mystery
'Cause
story.
you can't be taking notes the same way?
Can't take notes. So now I use that DAX Copilot that they have that records everything. Basically, I'm looking at the patient, I'm paying attention to everything that comes out of their mouth. It's funny because my patients think I'm a good doctor because I'm looking at them. I'm a good doctor because I'm trying to memorize what they're saying. When I do and try not to forget it.
Interesting. I'm curious, in what other ways are you a different doctor than you were before? Aside from the fatigue and certain limitations, but how did this change you as a doctor?
The first thing is I learned how to be optimistic more, especially at the end of the visit. Because when I would go see my other doctors, they'd look at my paper and they're like, oh my God, you almost died. I'm like, yeah, thanks. I'm here because I need a refill of. But they would always relive the whole experience again.
Yeah.
But the rehab doctors, every time you went and saw them, they would end the visit with like, "Wow, you're doing great. Wow, you did this, and wow, this is unique." So I translated that into my clinic, and I still do that to this day. I never just say goodbye, and I say, "You know what, you're doing really great," or "Hey, we've come a long way," or "I know this is the beginning; it's frustrating, but we'll get there." Some type of hope.
Yeah.
And the thing is, as a patient, when your doctor says you're doing good, you're doing good. Your whole day goes good. Your whole week goes good because you're doing good. So when a figure of authority like a doctor tells you that, it's such an amount of peace that you get that you really don't get with any other feedback. That optimism piece. And then number two, I'm very careful in how I explain things to patients because, again, people didn't know I was a doctor. And even before my stroke, my patients said I explained things very well. But I always thought they were being nice. They're my patients, whatever. I've known them for years. But when I became the patient, I realized these doctors were using words that I hadn't known until I had done medical school. And I remember sitting there thinking, man, if I was a regular patient, I would have not understood any of this. Maybe 1 or 2 words here, but that's it. Right. And so when I went back, I focused more on trying to show the patient, especially my patients, before when a patient had high blood pressure, I'd be like, you know what, go to your regular doctor for that. And I still do that. But what I do now is I say, look, the reason this is important is this. And I explain to them, like, look, this is what's happening. You should be bugging your regular doctor every month or every 3 months until this is under control.
Mhm.
And before I used to do that with my stuff, but now I'm
Yeah.
also doing it with other people's stuff so that they do follow up with that. The third was you're irreplaceable only to your family. So when at work, if somebody says you need to see more patients, or you need to do more work, or you need to do this and do that, or you need to be more productive. I'm like, you know what? I'll take a pay cut. I'm fine with that. I've always lived within my means. I'm still living within my means. I'll do it. That's no problem. But I'd rather take less pay and be functional longer.
I'd like to close out our interview with a quote that you put at the very end of the book. You quote Norman Vincent Peale
Yes.
saying, "Change your thoughts and you change the world."
Change your outlook. Focus on what you have. Don't worry about what you don't have. Don't spend too much time chasing what you don't have. Focus on what you have and make that better. In my case, it was just a matter of that lady couldn't walk again, but she could write beautifully. I can walk, so I could go back to work. I can do things. And even for the patients, a lot of my patients get deformities or they have rheumatoid arthritis, and so then they can't use their wrist anymore. Their wrist is just in one position now. That's fine, but you know what? You can still use your other wrist. You can use your other hand. We just have to work around this. So I try to lead them down that path. We can always work around something, but you guys have to be willing to work with me on that. That's the way that has changed me.
Dr. Shaiba Ansari-Ali, thank you so much for being on LabMind and for sharing your story with us. All of the listeners are going to find not just one item, but a lot in here that is going to be meaningful to them. And it certainly has been for me. So thank you so much for being with us today.
I'm honored to be here. I feel like the universe came together and saved me. So doing interviews like this, putting out those YouTube videos, and just letting people know that, hey, you can do this too. This is my only real way of giving back. I can't see 1,000 more patients in the clinic, but I can do this. So hopefully I'm giving back in some way, shape, or form. And I'm very honored to be your last guest.
Thank you. I really appreciate it. Before I sign off for this last time, I do want to add just a couple little personal notes. A huge thank you to all of the brilliant staff at ARUP's Institute for Learning. That includes our sound engineer, Isaac Acosta Alvarez, who always makes us sound amazing, but especially my dear friend, collaborator, producer, partner in crime, Sheree Peterson, without whom LabMind never would have gotten off the ground. And we certainly couldn't have come this far. So thank you so much for everything that we've been able to do together. And again, to all of our listeners, tune in next time for what will be the first of many new and exciting LabMind episodes yet to come, hosted by our dear friend, Dr. John Gensen. LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Sheree Peterson, with audio engineering by Isaac Acosta Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app, and please leave a rating and review in order to help others find the podcast.